Cangrelor obviously is the new drug that we've come across now, and some of us had the experience of using. And I actually used Cangrelor recently in 5 cases, and I actually had CD for 4 of them. But there's been some technical issues, so I might be able to show one CD at the end. But I'll tell you the reasons for which I used, at least in 5 of them, I can tell you. One of them was a guy who was vomiting. So obviously he couldn't retain his ticagrelor or anything. So we started by doing the case. He was an acute coronary syndrome, acute MI. So we gave him intravenous Cangrelor and carried on. By that time he settled, and then we gave him the oral ticagrelor and the aspirin, and he was salvaged. The second one was a lady who actually had interventions done to her circumflex before, and she came with acute coronary syndrome. We had permission for 1 stent, so we stented the tightest part. And after we finished, we saw a haziness in the osteoproximal area where there was a 50% kind of lesion with a big ramus coming off. So we were not keen to stent that because A, we had permission only for 1 stent, and secondly, it looked hazy. So we debated between using a GP2B3A blocker, or so we gave her Canreal, and she did fine. Third was a patient of, third was actually very interesting, a lady whom we did angioplasty to circumflex first for ACS, 98%, then we did PTCA to her LAD almost 2 or 3 months later, and then after the second angioplasty, she had fever or something 5-7 days later, and she stopped her medicines and came back with stent thrombosis. And she was in bad shape, low pressures, cardiogenic shock with sepsis, renal parameters impaired. And so what we did was we gave her Canreal and then loaded her up again with ticagrelor and the usual stuff. She survived, and of course, after she survived, because I think they had financial issues, so we never checked her artery later. But the fact is that her ECG resolved and she settled down. I think we were able to achieve at least survival in that patient, although we did not do repeat intervention, could not do. And then there was another patient who had, we put 2 stents in the LAD, and there was a diagonal moderate sized, and normally, we would have given a GP2B3A blocker. So here, with a little bit of slow flow, we decided to give Canreal, and the patient did fine. And I think the 5th one is a patient who was a acute MI patient who was having slow flow. So we gave Canreal and loaded up again with ticagrelor. So that's my experience of these 5. And I'm sure next time I'll be able to prepare the AVS slides and AVR files and put them up again. Today, I think we might be able to see 1. So I decided to go without it. So that's why as not to waste the time of others. So I just introduced my experience with Canreal. And so we all know about, coronary disease burden and then acute coronary syndromes. We need to load up patients, and that's always a worry. And then these don't get absorbed if we don't crush them. And sometimes even if they get absorbed after crushing them, there's always a time lag. We all know, even with 600 milligrams of clopidogrel or prasugrel, there are several hours of delay. And so meanwhile, when we go ahead, we are usually worried about, stent thrombosis. So often we resort to using GP2B3A blockers even now in patients who have not been pre-treated, as in ST elevation MI or many of the ACS who come by. So, and as shown here, delayed drug absorption, delayed onset of action, delayed offset. So because of these, and of course, drug interactions, because there's this worry about pantoprazole interacting with clopidogrel and drug interaction with other drugs. And so there's always a worry about stent thrombosis, even though we use this kind of loading. But in acute settings, we generally would like to use a GP2B3A blocker and also then follow it up with antiplatelet drugs orally. So this is the delayed peak effect, as you see here, in patients who have been loaded orally. So there's a delayed peak effect, usually around 6 hours. In some cases, some of the drugs like prasugrel may be a little earlier. And with 600, it could be that. But I think the data also is lacking on what exactly is the best dose. Of course, there are 1 or 2 studies which have actually shown that, using 600 loading probably brings on the effect earlier. So that's where the gap is, and there's one reason to use either GP2B3 or Cangrelor in that kind of situation. And the advantage of Cangrelor is, of course, that the onset is within 2 minutes and the offset is within 60 minutes of stopping. That's obviously probably a bigger advantage compared to GP2B3 blockers, because when you stop GP2B3 blockers, even with the teriflunomide or eptifibatide, I think the effect still goes on for at least, maybe 6 to 8 hours or even 12 hours. So that is, of course, one advantage, that the offset would definitely be within 2 hours, if not within 1 hour. So in management of CAD, as I've said, the rapid onset of action is a big advantage, and the fast offset of action, mostly by 60 minutes, the action is gone. And that's the dosing which all of us can actually go through. And transitioning to oral therapy, one is recommended to actually, once you start this, for using prasugrel or clopidogrel, that should ideally be done after the infusion is over. Because the problem is when you use these thiopyridines, the clopidogrel or prasugrel, then the binding actually, they need to be activated. And once they are activated, they bind with the receptors, the P2Y12 receptors. But when you give Cangrelor, then it's kind of 98.8, almost 100% binding. So the clopidogrel actually can't work because it can't get attached to those receptors. So it actually kind of becomes redundant in that scenario. That's a very important point, actually. So if the patient's been loaded with clopidogrel or prasugrel and you give Cangrelor, then the previous loading all becomes redundant. So you actually have to load after giving Cangrelor if you're using prasugrel or clopidogrel. But if you're using ticagrelor, you can actually load them together, because the basic mechanism of working is the same for both, and that's binding of the P2Y12 receptors. So that's again shown here, that how the loading is done for the 3 drugs. And pharmacodynamic advantage, as I've said, is that the quick onset of action and the quick offset compared to GPI, fast onset, and the platelet inhibition is far more rapid offset in an hour. CKD friendly is another very important point, because you need to reduce dose here for GP2B3A blockers. And this is another concept, is the natural bridge, which we'll come to later. So in terms of recommendation or approval, I would say that Cangrelor has a place already as an adjunct to PCI, for the same reasons that we would use a GP2B3A blocker, reducing periprocedural MI, to reduce repeat coronary revascularization need, and of course stent thrombosis. And that is in patients who have not been pre-treated with oral. So somebody who was on regular oral P2Y12, you would probably just give an additional 300 milligrams and get on with it, rather than going for GP2B3A blocker or Cangrelor, unless there was a specific reason, to use a GP2B3A blocker or Cangrelor. And the European Society has also sort of restricted it to its recommendation to use in patients who actually have not been pre-treated. And it's like a naive de novo patient coming with an acute coronary syndrome or ST elevation MI who needs an intervention. So he's never been loaded before. So when you load, again, you land into those issues of late onset of action. So the initial 6 hours are not covered when you're doing the intervention. So you have to reach for a GP2B3A or Cangrelor. So that's where they have given the recommendation for use of Cangrelor. So there's some clinical evidence. These 3 trials it was studied in, as Dr. Roy mentioned, he was part of one of the studies also. And of course, the advantage has essentially been seen with the Phoenix study, which is this one. And of course, this was compared with clopidogrel, 600 or 300 milligrams. And it's being called a landmark analysis, where there was a significant reduction in the event rates with use of Cangrelor infusion compared to clopidogrel. Stent thrombosis within 48 hours was significantly lower with Cangrelor. And the composite of death, MI, and ischemia-driven revascularization and stent thrombosis within 48 hours were significantly lower with Cangrelor compared to clopidogrel. And as you see here, Cangrelor was better for these endpoints in 48 hours. And when they did a meta-analysis of all the champion studies, of course, this is essentially driven by the champion Phoenix study, that you find that the composite, as was found in Phoenix, endpoint of death, MI, IDR, and stent thrombosis was actually lower with Cangrelor compared to clopidogrel alone. So these endpoints were found to be favorable with Cangrelor. This was a large study, and if you look at stent thrombosis, there was a significant reduction in STEMI, which is, the NST, ACS, or STEMI are the two important areas where one would want to focus. But if you look at the difference here, the p-value, not really much. So stent thrombosis, when it is taken as a composite, then you find a significant difference, but not really significant in ST elevation, MI. But when you look at 30-day stent thrombosis, you find a significant difference compared to clopidogrel. So I think overall there is a benefit in stent thrombosis. May not be in ST elevation, MI, evidently in that group. There may not be any significant difference, but clearly there is and that too in intraprocedural stent thrombosis, but clearly there's a difference when you look at 30-day. So the effects are probably up to 30 days. The benefit is up to 30 days. And so on that basis, the FDA gave approval to Cangrelor for use in this subset of patients. So in the CANTIC trial, again, they looked at platelet inhibition. I think this was a in vitro study where they looked at the PRU, which is the P2Y12 receptor units. And they found that there's a significant blockage in those units with the 90% platelet inhibition within 5 minutes, and which comparatively took 3 hours with monotherapy with ticagrelor. So obviously, when we give ticagrelor, that was kind of an advantage over the clopidogrel and prasugrel. But when you look at the Cangrelor, you find that the platelet inhibition of 90% occurs much quicker within 5 minutes. So in an acute setting, obviously it makes sense to go with this, so that this is probably equivalent or probably better, because if you look at the time of onset of this drug, it's probably even better than GPI. So clearly this would be an advantage in the acute coronary setting where the patient's not had P2Y12 blockers before, and you're going to take the patient on for PCI, and you want to keep the risk of stent thrombosis low. So this is a retrospective analysis, single center retrospective analysis, which was done comparing GP2B3A with Cangrelor, and that did show that bleeding events were less, MI was less, and total hospital stay was less. So clearly, I mean, this was a retrospective study, so it might have its limitations. But at the same time, we know that because the Cangrelor time of onset is quicker and offset is also short, so it might be the best thing in patients with acute coronary syndrome, where you have to take the patient on table without waiting for the loading dose of oral tablets to take effect. Again, coming to bridge. A bridge is a situation where we all have faced that, you put a stent or something, and then, patient has to go for a surgery or even CABG. So in that scenario, sometimes, you take a patient on table, angio plus minus PTCA, but you want to load beforehand so that the effect is there if you want to proceed to PTCA. And then you find that there's some complex 3 vessel, and so you don't want to do angioplasty, you have to send the patient to surgery. So now the patient has to go to surgery with all that loading dose of clopidogrel aspirin. Some of the surgeons would be happy operating even with that loading dose. They might wait 3 days, or they might operate next day. But I think more people would want to wait a few days for that effect to wear off, And so that's risking the patient's condition, because now you have to wait 3 days. Or if the patient has been on regular dual antiplatelets and now the patient needs a GI surgery or something, and which is urgent, and you can't wait for too many days. So in all those scenarios, I think the best is if the patient can be put on some kind of a therapy where the stent doesn't get blocked, and this has a short offset. So you stop this like 2 hours before surgery, then the patient can go for surgery. So instead of preloading where patients where we know it could be angioplasty minus angioplasty, and we are not sure, so we could use this, maybe even with aspirin, doesn't matter, and do the angiogram. And if you do an angioplasty, then you go on to oral loading, as has been shown, into converting the intravenous to oral. And if you don't want to go ahead with angioplasty, then nothing is lost. You just stop the Cangrelor, effect goes, and most people would operate the next day in that scenario, or maybe even after 4 or 5 hours, of stopping Cangrelor, because the effect is gone in 60 minutes, maximum 2 hours. And in scenarios where you have a patient who's been on dual antiplatelet and now they have to stop that, and the stent is recent. So now, rather than saying that, so if he's waiting 5 days and we are risking subacute thrombosis because he's on clopidogrel, or 7 days if he's been on prasugrel, then we could actually stop that, put him on Cangrelor for that time. And then once that period is over, his risk of subacute thrombosis is minimized. And then he goes on to surgery once you stop the Cangrelor, and he goes to surgery between 2 to 7 hours. So that's the concept with bridge. These are the situations where the bridge study was done in these kind of patients. And the bleeding endpoint was, of course, not significantly different compared to a placebo. So there's no major bleeding issue. And ischemic events were definitely less when they used Cangrelor rather than placebo. And a summary of that bridge study is that when you use that as a bridging strategy to CABG or even other non-CABG surgeries, then the bleeding risk doesn't increase much, but the risk of having an event becomes less. And it is independent of prior thienopyridine dose and time of discontinuation, because moment you start Cangrelor, it's actually the previous drug becomes ineffective. So the P2Y12, the thienopyridines, they become ineffective. So you could start stop today and start tomorrow. It's not going to be a problem, because it's not going to increase the bleeding risk, because it's the thienopyridines who become ineffective once you start Cangrelor. So it works fine. And so that it's a concept, because I don't think we have real hard data, because in this basically it's a concept which says that this is what can be done. I don't think there's a large study on that, or a randomized study to actually say that this could be part of a guideline. But clearly, it could be put into practice because it makes reasonable sense, rather than wait for 5 days with no antiplatelets. Instead, we can give them Cangrelor while they're waiting for their thienopyridine effect to wear off. Whenever the surgeon is happy to operate, this can be discontinued, and Cangrelor can be discontinued, and the patient will go for surgery. So again, coming back to the approved status as of today is for Cangrelor is to reduce the risk of periprocedural MI, repeat coronary aspiration, stent thrombosis in patients who have not been treated with a P2Y12 platelet inhibitor and not being given a GP2B3A inhibitor. So it's kind of substitute for that with more advantages, because quicker onset, quicker offset, less bleeding risk. And as bridge therapy for patients receiving antiplatelet therapy during surgery, as we just discussed. And of course, in patients, as I said in the beginning, about my patient who was vomiting and could not receive oral medications. So this can be used across the spectrum of coronary artery disease, including stable angina patients. So again, ACS, this is a concept where you can use Cangrelor rather than preload them with dual antiplatelet if we are going to go into an angio plus minus or a query proceed to PTCA. We're not sure whether the patient might go to surgery also. So that could be one option. In clopidogrel resistant patients, of course, when you load them and they're resistant, then of course you don't get the effect. So that would also be true if you gave Cangrelor and then loaded them with clopidogrel, the same thing would happen. So, I mean, if you're going to give ticagrelor, then obviously you are circumventing the clopidogrel resistant patients. And again, as a bridging for CABG and non-cardiac surgeries in patients who have been on thienoperidines and you want to stop and then prevent the stent thrombosis with Cangrelor and then take them on for surgery. And the cost and need for GP2B3, I think more important is the onset offset, compared to GP2B3, which is more appealing here. And of course, like I said, I've used in one complex case, and that's intuitive. People, if they want to use GP2B3A, whether they can use in this, it's up to them. Be kind of off-label, not enough data on that, but that's an area which is probably going to be explored as well. And intra-procedural stent thrombosis, of course, that is something which I think is not much of an issue, but clearly stent thrombosis overall for 30 days is a big issue. It's not only intra-procedural. So using Cangrelor does make sense if you're using in this setting of acute MI or ACS where patients have not been pre-treated with P2Y12 receptor blockers. Thank you.
Thank you, Dr. Sanjay. It was an excellent presentation, a comprehensive view of where Cangrelor could be very useful. And I definitely agree with you on a couple of points that it's been a boon to us, considering the fact that the use of GP2B3, there used to be a lot of concerns about the bleeding risk. And the major advantage of Cangrelor is the shorter duration of the offset duration of its use. Having said that, I think for the benefit of the viewers, we need to discuss. You actually pointed out a couple of real-world uses. One is a P2Y12 naive patients when you're doing an ACS where there is a time for the absorption of the drug. And you can easily use this, particularly in situations where there is a high thrombus burden and you are doing a STEMI-like or NSTEMI-like situation. That's one. Two, an instant thrombosis. Third is a bridging. Of course, bridging, as you already said, that we do not have any concrete data on it. And 2 to 7 days of therapy is in our scenario, maybe prohibitively expensive. If I'm not wrong. So in real world, most of the time, the use is predominantly in situation of acute coronary syndrome, high thrombus burden, P2Y12 naive patients where you have initiative therapy, or in patients where we cannot administer the P2Y12 or the ADP receptor antagonist like the ticagrelor, and this can bridge that situation. If you would like to add any other situations where it can be used.
Yeah, true. I mean, patients, if they are not able to take orally and or if they're vomiting, so in that scenario, and you want to get on with it, you don't want to wait for him vomiting to settle, then give him the loading, then the onset of action would be at least 3 hours. So I think it makes sense to, just treat the vomiting and get on with the case quickly. I think that would be surely one. But in other situations, again, if the patient's unconscious, you can still put a Ryle's tube and give it. But again, the onset would be 3 hours at least, getting it absorbed even if you crush it. So again, so I think in most of these settings where you don't want to waste time, I think this is a drug which has immediate onset of action. I think that is where the biggest boon of this drug would be, as you rightly said, boon of onset and offset.
So is there a concern of yours for, this is given in the 2 hours, infusion, and the action of the oral P2Y12 or the ticagrelor will take about at least 3 to 4 hours. So once you stop the infusion after 2 hours, there'll be a rebound phenomenon in that window period. Is that your concern, or you would like to extend your use of beyond 2 hours?
Yeah. This can be given. This can be given longer. This can be, as people have even given for 7 days. This can be given longer if that is a concern. If your procedure is prolonged, you can give longer. If you want to give 4 hours, you can. So the thing is, if I start this and the patient is not vomiting, able to take orally, and I give loading dose of ticagrelor by, crush it and give it, the action would be there, and while the case is being done, and so we could continue 2 hours after the case, so you have enough coverage in those 3 hours, and you can give 3 to 4 hours, 7 hours, not a problem. Can be given one.
So I think many of the viewers or listeners may not have used the Cangrelor. Would you take us back to the first, third or fourth, slide of yours as the way to start the drug doses?
Okay, so yeah.
You can go slow by slow for the benefit of the viewers.
Okay, there we are. So recommended dosage of Cangrelor, 30 microgram per kg intravenous bolus, immediately followed by 4 microgram per kg IV infusion. And of course, there's no dose required in elderly, patients with liver dysfunction, patients with renal dysfunction. And so approximately in somebody who's 75 kg would require 11.25 ml of intravenous bolus. That infusion would be 90 ml of Cangrelor for 1 hour. So that's the dosage.
So any concerns for any drug interactions or the side effects or anything that we need to look for?
Actually, there are no drug interactions because it just binds the receptor, so it doesn't interact with anything. So that's the big advantage over the other P2 vital, the oral tablets like clopidogrel and thienoparidines, the clopidogrel, prasugrel. The other thing is in terms of side effects, A, bleeding, which again is less than GB2B3 blockers and comparable to clopidogrel. And B, in terms of side effects, there could be minor side effects, which at least I didn't see in any of them. Things like diarrhea or a little bit of breathlessness in about a 1 out of 100 or something, like you can also have with ticagrelor for the same reason, because the mechanism of action through the ATP, the adenosine pathway. So other than that, there's no major side effects of this drug. Some GI symptoms, nausea, vomiting, that's about it. So, and I haven't seen any. And with ticagrelor, we don't see any. So I expect that, this would be as safe because it works on the same mechanism.
So I have a question for you from Dr. George Koshi, and he wants to know, compared to prasugrel or ticagrelor, is there a reduction in the acute stent thrombosis with Cangrelor?
Compared to clopidogrel, there is, but with prasugrel, probably not. So I think the advantage is not in terms of what you want to make better by using prasugrel. It's only the time window because of its quicker onset. And so if it's comparable to clopidogrel in terms of being non-inferior or actually being better with clopidogrel in the Phoenix study. So the biggest advantage is in the quicker onset and the quicker offset and being comparable rather than being superior to prasugrel.
Okay, and he has also asked, can Cangrelor be used as a coronary intravenous?
No, the dosage is only intravenous infusion. There's no intracoronary. It's not been used. It's not been used. Yeah.
Right. So I think if I may be a little bit bold to say that with the advent of Cangrelor, perhaps the use of GP2B3A will wane off. How do you foresee that?
Yeah, I think it would. I think, like with any new thing that comes, with any change that happens, it takes time for people to accept and switch. And then there's the, issue of, the approvals from the hospital accepting it as an equivalent. And then we have the panels, if you have panels, if you have various organizations who send their patients, whether they would accept that as an equivalent, that takes time. And, they need to be given the appropriate data. And so those become the limitations. In somebody who's a cash paying, it might be much easier. But even if it's a patient who's being paid by an insurance company, would probably want to know what this drug is and why this was used and what the other. So, these would be the initial hurdles in its acceptance. But in terms of, and of course, the awareness in the minds of physicians and their own viewpoint on that, their own thought processes and their own evaluation of the drug and their own experience with the drug. I mean, these would matter in terms of, because GP2B3 has been used for very long. If you look at the long experience people have had with these drugs, and most people are not using it except in acute setting or just as a bailout. And with bioavailable, again, bioavailable and Cangrelor is a very great combination. There's no problem with that. So, people can actually people actually switched to bioavailable to reduce the bleeding risk with GP2B3A and heparin. So, and here there's no increased bleeding risk when you use bioavailable and Cangrelor. So I think people will have to develop their own experiences and they have to make up their minds about what they want to use. But I think there would be a slow transition as people get to know about the drug, get to know about it, and then start using it, and then feel confident about it. And then they feel, okay, this is better because it's quicker onset and offset, and the bleeding risk is less. I don't have to worry much. If there's a bleed, I just stop it. The matter ends in an hour. That's also a big kind of solace in the mind that don't have to worry, because a lot of these patients, as you know, have acid peptic disease, or you worry about their GI bleeds, or so it would be an advantage definitely, but it's a matter of time for the physicians to accept and practice, and then develop their own experience and be comfortable with it. And the second thing is the organizations, the patient side, the payers, the people who are paying for the patients, they have to be aware of the drug and its advantage and its current niche, and be able to accept that this is a drug which has its own place and is superior in certain ways, and so if it's used, then it's equivalent and should be reimbursed. So then I think the issues would fall in place. So I expect that this would happen in the next 3 to 6 months, and so there should be a pickup on the utilization. That would be to patients' advantage, and I think it would be a relief for physicians on account of its quick onset and upset.
So I have a question for you from Dr. Gokhale Bhopal. What are the risks if we use in any patients who are already on ticagrelor?
No, there's no risk. There's no risk, because we load patients with Cangrelor with ticagrelor, right? Now the problem is, if somebody is on ticagrelor, why would you want to give Cangrelor? You would want to give Cangrelor because there's some other problem. The patient has probably stopped his medicines and has had stent thrombosis. Why else would we want to give Cangrelor in somebody who's already on ticagrelor and doing fine? So if the ticagrelor has failed, then there has to be a reason why ticagrelor has failed, right? So if you take the patient on table and you want to use GP2B3A blocker, so your ticagrelor probably has not worked or has not been taken. And in most cases, the patients would say that we are taking, but they have not taken for whatever reason. And so in that situation, again, you're landed with a situation where you want to restart the thing. Like if a patient comes with stent thrombosis, you want to do an angio and query proceed, you reload them with ticagrelor because you think this guy might not have taken his tablets. Why would he have stent thrombosis on ticagrelor then? So I think with that logic, it can be used. And the other thing is, the only area where probably combination would not be advisable is in somebody who's already received thrombolytic, or somebody who's already used, you've already used GP2B3A blocker. In that scenario, I would be very wary, because the bleeding risk is going to be very high. Like you have with thrombolysis and GP2B3A blocker, the risk of bleeding would be very high. So that would be kind of an area where I would not. But other than that, I think if a patient's been on ticagrelor and is requiring an intervention because there is a thrombotic issue, then obviously ticagrelor has failed because it's not been taken probably.
Now, let's say if there is a situation where patient is already on ticagrelor because of the stent there, and patient has a different vessel which has infarcted. Okay. So in that situation, would you like to use Cangrelor, or would you like to continue without even giving a Cangrelor primary of that vessel, the other vessel?
If somebody is on ticagrelor and is having a MI, I would probably, because the patient's already having the drug. So we normally wouldn't reload the patient in this kind of scenario. So I would probably make sure that he's been actually taking his meds and just get on and do the case. If there is an issue, kind of bailout situation, then we have to take a call between Cangrelor and using a GP2B3A blocker. And I think that would be up to the physician. I don't think I would be able to give a comment on that, because there's no data on that. But I think such situations would be rare, because somebody who's on ticagrelor is now having an MI, then normally we wouldn't reload them, right? So we would just get on and give heparin and do the case. And if there's an issue like more thrombus or a bailout situation, normally we would use GP2B3A blocker. And of course, in all these studies, they have actually used on patients who've not been on P2Y12 blockers, receptor blockers. So ticagrelor is one of them. So if they've been on it, then Cangrelor doesn't make sense really. So if it's not been missed and he's on it, then I would just get on and do and use maybe GP2B3 blocker as a bailout.
So are there any other questions? Any final words from you, Dr. Chugh?
Yeah, definitely, sir. So I don't find any other question is there in that now. The last question, Dr. Bhopali from the Bhopali has asked the question. So before closing, I'll take the few minutes, and Dr. Sanjay Chugh, sir, you can also give some few words regarding this Canreal or the Canreal uses of that, sir.
You want me to share my slide or stop sharing now?
No, we can stop sharing, no problem, sir.
Okay.
You can stop sharing, and if you want to give any message to the audience, you can also give that message to the audience. But what I found, sir, you have clarified that the doubts, whatever there was there, uses of Canreal is very neat way so that the participant, everybody can understand the how it can be used and the benefit of that. So before we close, I'll just share one slide. So in MSN R&D, in Indian Canreal, ticagrelor was first considering along with the Canreal what we are talking about, and the team of scientists has developed the process of making this Canreal, and the core team with year of struggle they manufactured this ticagrelor in India first. They have developed the pilot batch, developed the commercial batch, and at the final way they have manufactured the TRA, the ticagrelor in India, and that plant also approved by USFDA. As we was talking about, the Canreal also one of the part for this particular therapy. So if you see the MSN platelet range, that is TRA and TRA kit with combination therapy and the. So, sir, we may be the young player, but our drive and enthusiasm are the best in associating. Thank you. So, on behalf of the team MSN, I'd like to thank Dr. Chugh for your detailed explanation of the today's program and the clarification of attendees' doubt. So, thank you so much. Good night, sir.
Thank you. Good night.
Dr. Rai,
Good night.
thank you.
Thank you and good night.
Thank you.
Thank you.
Good night.
Thank you.